Hi, I'm Alan Braverman. I'm the director of the Marfan Syndrome and Aortopathy Center at Washington University in St. Louis School of Medicine. And on behalf of the GenTAC Alliance, I'm going to present today information on aortic root and ascending aortic replacement in Loeys-Dietz syndrome. And this is an update from the 2022 ACC-AHA aortic disease guidelines provided by the GenTAC Alliance. Loeys-Dietz syndrome is recognized to be due to pathogenic variants in genes encoding the receptor for TGF-beta, TGF-BR1 and 2, and other genes that affect the signaling pathway, including SMAD3, TGF-B2, and TGF-B3, and has features which can overlap that seen with Marfan syndrome in the skeleton and others, but has differing features that can discriminate, including club feet, translucent skin with visible veins and velvety skin, facial milia, widened atrophic scars, and easy bruising. And it often has a characteristic triad to help recognize this phenotype, including craniofacial features, especially bifid uvula, wide-set eyes, bluish sclera, tortuous arteries, and widespread arterial and aneurysm disease at earlier ages in some, and much more aggressive in others compared to the Marfan syndrome. In the earliest papers on Loeys-Dietz syndrome, this one from the New England Journal from Bart Loeys and Hal Dietz and group in 2006, emphasized the early onset disease, the more widespread arterial and aneurysm disease, and the emphasis on some precision, even then, in the earliest recognition in those who had more severe craniofacial features having an earlier onset disease and more aggressive disease. This important paper from the International Registry from the Montalcino Aortic Consortium looked at a much larger group, 441 patients from 228 families with 176 and 265 with TGF-BR1 and TGF-BR2 variants, respectively. In this group, the survival was 80% at 60 years. 23% had experienced an aortic dissection, 18% with preventive aortic surgery. And even then, a recognition for some precision and variability between the genotype and phenotype, with diameters at the time of dissection tending to be smaller in those with TGF-BR2 variants, especially in women with more systemic features. 6 individuals experienced a type A dissection with a diameter of less than 45 millimeters. The 2022 ACC-AHA guidelines provide information about managing Loeys-Dietz syndrome with various pathogenic variants. For all those with Loeys-Dietz, a baseline MRI or CTA from head to pelvis is recommended to evaluate the aorta and the branches for aneurysm, dissection, and tortuosity. An annual imaging of dilated or dissected segments is recommended for follow-up. And when the arterial segments appear normal, periodic imaging over time, perhaps every 2 years, is reasonable, with cerebral imaging every 2 to 3 years. In our series of 80 individuals with Loeys-Dietz syndrome for whom screening for intracranial aneurysms was performed, we detected those in 20% of individuals. And they did occur over time, emphasizing the importance of follow-up. In this important paper from Dr. Milowitz and her group from the Montalcino Aortic Consortium, 1,000 individuals with rare variants and 7 heritable thoracic disease genes were looked at for cumulative probability of first aortic event, aneurysm repair, or dissection. We're going to focus on the 4 genes related to TGF-beta signaling, the Loeys-Dietz family of genes, to emphasize the importance of understanding the gene and then aortic events. In this series, the cumulative probability of a first aortic event, aneurysm repair, or aortic dissection did differ with earlier onset disease with those with TGF-BR2 compared to other genes, and later onset for those with SMAD3. You can see the 50% probability being up to 15 to 20 years earlier in those with TGF-BR2 gene variants. The ACC-AHA guidelines emphasize gene-specific recommendation for surgical thresholds for prophylactic root replacement in genetic aortic disease. And in Loeys-Dietz syndrome, those decisions about aortic surgery involve shared decision-making. So for those with Loeys-Dietz syndrome and aortic dilation, the surgical threshold for root and ascending replacement is informed by the specific genetic variant, the aortic diameter, the aortic growth rate, extra aortic features, the family history, the patient's age and sex, and physician and patient preference, and the expertise of the center performing the surgery. And one can see the different variants can have different aortic diameters that are also informed by the presence or absence of high-risk features. And surgery is recommended at smaller diameters in those with Loeys Dietz with high-risk features that associate with aortic dissection or with rapid growth. And some of the high-risk features, again, TGFBR2, then TGFBR1, small body size, severe extra aortic features, and a family history when of dissection when that occurs in small aortic diameters. So you can see how 4 centimeters may be very appropriate for some with certain variants and certain phenotypes, where a larger diameter up to 5 centimeters may be more appropriate for a TGFB3 patient. On behalf of the GenTAC Alliance, thank you very much for the opportunity to present today.